It's a different case than we discussed about 6 months ago. But this is a case, again, I think I felt we probably should rediscuss again. Recently, if you can see, this 91 years old woman presented to the hospital on 24th of October last year, and they felt she has postmenopausal PB bleeding, background history of advanced dementia. She has a known diagnosis of early stage CLL, and she had a DNS CPR in place in the community and a resident at care home. These two things, you just remember: elderly, residential care home patient, advanced dementia, and she is coming in with symptoms of bleeding. Very important, these couple of things. She had an MRI pelvis performed following her ultrasound, and which showed likely a bladder clot or hematoma, in addition to the mild diffuse endometrial thickening. So probably they were thinking dysfunctional uterine bleeding, old age, etc. Just remember this. So you decided to do the blood test, obviously not us, by the medics. And what you can see, this is consistent with her CLL, very long-standing problem. She's not been treated. Very stage, this is, so for me, what stage of CLL, if this patient comes to you with lymphocytosis, normal neutrophil, platelets okay, and just assume patient she's demented, no B symptoms, no bulky lymph node, what stage of CLL does she have? Non-bulky lymph node, probably you have done an examination or a scan, and no B symptoms, assuming she's talking and telling you, and she has lymphocytosis with normal hemoglobin, normal platelets. So what stage of CLL she is?
Can I ask organomegaly?
There's nothing, no.
No,
I told you there's no bulky lymph node or organomegaly.
Breast is what?
Even if she has bulky lymph node, you see, the stage is probably is going to be 0 or 1. Yeah, absolutely. Yeah, early stage. So interestingly, you have, obviously she's bleeding, elderly lady, doesn't talk to you, you're going to do the clotting test done, and the clotting came back as isolated prolongation of the APTT with APTR ratio of 1.98. And remember, her fibrinogen is okay and her PT is normal. She's not on warfarin. So what test would you like to do next? A patient with bleeding and prolonged APTT. So what would you do next, and what are you thinking?
Anybody?
Anybody, yeah?
Oh, okay.
Yeah, anybody, yeah.
Well, let's see. I know platelet count is normal, but let's see our LFTs first. And then...
That's interesting you said, if her LFTs were deranged, would you see isolated prolongation of APTT with normal fibrinogen and...
No.
Yeah, okay. And APTR is a bit high, isn't it? I mean, if you see the APTT is about 40, that probably a bit liver related. But with the prolonged APTT, APTR of 60 and normal PT, liver dysfunction is unlikely. Remember this. So Harriet has been called about this obviously very high APTT. Elderly lady, doesn't communicate much, dementia, came from care home, and she has bleeding. What would you do next for her? You must do something.
Would you check her with the medication?
Yeah, absolutely. Very interesting. So what medication can give rise to isolated prolongation of the APTT, APTR, and bleeding? Is there any drugs you can think of?
Dabigatran?
Yeah, interesting. So isolated prolongation, what dabigatran does? What is the mode of action of dabigatran? Is a direct thrombin inhibitor. So we not generating enough thrombin. So if we don't have thrombin generated, the prolongation of the APTT on its own is unlikely. It has to be both prolongation of the PT and APTT, and it's quite significant. You see 60. So she is not on dabigatran. you're very right. So she's not on heparin. She came to A&E from nursing home. So nobody in nursing home will inject her IV heparin to give rise to prolonged APTR. So this is again against heparin contamination or intravenous heparin. So you say it could be intravenous heparin, dabigatran, and other anticoagulant is unlikely. Rivaroxaban and apixaban, isolated prolongation of the APTT is not consistent because they get more prolongation of PT than APTT, but both can be borderline raised. So any just remember for your exam and all the time, you just any prolonged APTT or abnormal LFTs, the clotting needs to be repeated, pre-analytical variables. So because here is a bit different. We know she's bleeding. If quite often you will find the clotting is deranged fast time, and you repeat it about 15-20% is absolutely normal. So the first thing you say, any abnormal clotting needs to be repeated and reproduced. So important, very important. And you have advised that, but when you went into the computer and you found she has, you see, so her APTT started to go off since March 2017. And you see, it started from this 37, and once it was 60s, and then you see fluctuated a lot. So you see 37 and went up to 75 and then 51. So the highest was when she came in, you see, it was 60s, yeah. But prior to her admission, you see, a few months before, she had a prolonged APTT, probably APTR as well. So what are you thinking now? Bleeding with a few months history of the prolonged APTT, not on any medication, she's not on heparin, nothing. You repeated it and you have seen it is prolonged for quite a while. What are you thinking? Tell me.
Well, she's bleeding, so it can't be lupus. So you are thinking
It can't be lupus, you said.
it
Okay.
likely isn't lupus.
Okay.
Because I'll still do a mixing test and rule out lupus.
Uh-huh.
But because she's actively bleeding,
Mhm.
and with lupus as a differential, maybe will be there, but lower down.
Yeah. So lupus is a differential, but lupus bleeds or clots?
No, there will be no bleeding. She has lupus. Because
She's
she has
bleeding.
bleeding.
She
Yeah,
came in
that's
with the
what I'm saying.
symptoms. So it's unlikely to be lupus.
Yeah, that's exactly.
There are some situations which you need to read. The lupus patient can bleed. Okay, rarely, extremely rare, but she probably doesn't have. But you are right to say that we will be thinking of could it be a lupus as well. So okay, so is it the first test you want to do, or lupus test? Or
Mixing test.
okay, so tell these juniors about the mixing study. We'll come here later. What do we do? Basic of
Just
the
mix it, do a 50-50 mix with normal plasma.
yeah.
So if it corrects,
Yeah.
that means the plasma you put in, just putting it simply, it does have the factor. So if it corrects the factor deficiency, most
Yeah.
likely.
Okay.
If it doesn't correct,
Yeah.
it's an inhibitor, because the inhibitor persists. It will keep inhibiting the reaction.
Okay, fantastic, good, very good. We'll talk about immediately acting inhibitors and delayed acting afterwards. So you're thinking of it could be an inhibitor, bleeding, etc. Okay. You have done you said the liver function tests, and they're not bad actually. They are fine, and she's elderly, 91, and she has a bit of long-standing chronic kidney impairment, which is not new actually. So you have done the mixing study, and it's even more prolonged. So what do you think? It's not correcting.
It's not
So it's
correct.
unlikely for her to have a factor.
Deficiency.
Okay, factor deficiency probably, but due to an inhibitor. Okay, it will be a factor deficiency, but there is an inhibitor which is destroying even the patient's controlled 50% plasma in tube. This is what I'm trying to say. MRI scan, as you said, Harriet went to see, and she didn't go, as you saw, and there is a bit of bleeding hematoma here, as you can see, which was evident previously on the ultrasound. Okay, so she's bleeding. So what are you going to do now? You establish it's not correcting. There is an inhibitor, right? And patient is bleeding. will you wait for the specialized test result to come back, because it might take a couple of days? In our case, it took about 3 months, 3 weeks. Will you wait, or will you do something about
Which
it?
test is specialized now? I'm sorry.
So,
Is it the Batista?
yeah, so
we
many of the UC District General Hospital are not able to do the.
So how long did you wait for a test? How long did you wait for a test?
We waited about, there was some initial sample got lost and so others. So you see, it's about 3 weeks.
We used to do that
It's a different thing.
every day.
No, it's a different thing. I think it's probably a bit of various things contributed here. So what do you want to do? A bleeding patients, and you have done 50-50 mixing study as a baseline, which take 15-20 minutes, and there is an inhibitor. You want to wait for the inhibitor study?
When it takes such a long time, so I'll treat.
Okay, so you're going to treat this patient, and how are you going to treat this patient? What treatment are you going to give?
Well, I want to stop the bleeding. That's the most important thing.
Yeah. So local measures. So if she's bleeding externally, but you can't do anything about her bladder, she's bleeding internally. So what product component you're going to give?
Fiber or Novo7.
Okay, so you're going to give Novo7 or FIBA, prothrombin complex concentrate activated. Will you give factor 8?
If you give factor 8, it's just going the inhibitor's just going to act on that factor.
An amnestic response, and you will have lots of the inhibitor coming up. So you should never give factor 8. Okay. So you're giving PCC or Novo7, never give factor 8. Right, good. Rightfully you said you have done a lupus study, yeah? And the lupus test result came back like this. So APTT insensitive is still prolonged 35, and they said she has got a lupus anticoagulant detected. So it is having an inhibitor, delayed acting, and the lupus combination is extremely unlikely. So why this lupus screen was detected positive? Do you think it's a false positive or it's a true positive?
Well, the delivery ratio is slightly prolonged.
Yeah.
Insensitive. So the APL is insensitive. Because insensitive to lupus is that second test.
Yeah.
So it's insensitive to lupus. So that's also prolonged. And then the active FS is prolonged.
So
It looks like
the basic, just remember, it's a falsely positive actually, the lupus positive. And if you see a lupus locally reported like this, you might get distracted and say, oh, patient has got an inhibitor and bleeding is probably unrelated to the prolonged APTR, which was thought to be the case in this patient. You always do a test we call DRVV, DRVT, dilute Russell venom beeper test, and you see still prolongation, but you have to retest it again with addition of the highest dose of phospholipid for you to say it's a phospholipid dependent prolongation of the clotting. And if you add on more phospholipid, it's partially get corrected. So you always have to do the two-stage testing. Whether this was done in this case or it was just DRVVT, and they said assume is a lupus anticoagulant positive, having found prolonged APTT, we don't know. I will investigate that further. But this is, I think, probably is a one-stage test, and they assume this is a lupus positive. But if they had done additional phospholipid into tube and retest, they would have seen the correction, you see, because it's a phospholipid-dependent anticoagulant in the blood. So that was the, I think, problem.
So that's a screening.
Yeah. So lupus was falsely positive, and as I said, the basic case, you have to do the two-stage study before you confirm and suggest. So specialized test for the inhibitor study went into Royal London Hospital, and you can see that this patient, the factor, I think, which was when we tested here, it was 0.06. This factor 6.8 on a presumptive diagnosis of the acquired hemophilia with poor correction post-steroid actually. She, by now, I think she had about 2 weeks of the steroid as an inpatient, and her factor went up from 0.06 to 6.1. And if you see, all the other factors are all absolutely normal. So this is, you might say, factor is 6.1, so, but this is post-steroid. It came up. By this time, Harriet did manage to send a sample or asked the team to send the sample, she already had 30 milligrams of the steroid suggested by Dr. Chirby as a palliative treatment for acquired hemophilia, and this is what you see, the Royal London Lab, and all the other factors you see is all normal. And you see the inhibitor study, what we call Bethesda unit, is probably in the lower, down 1.3, probably it was 5 or 6, but it came down as well because patient is on steroid. And Sean Platon was a quite good guy. He got lots of training for us. He's consistent with diagnosis of acquired hemophilia. Her APTT is also 39. He's a 92 years new residential home patient. Recently, actually, she was discharged only in December, I think, home. She went home in December, nursing home. So the diagnosis is acquired hemophilia A because the factor 8 was 0.03 and post-treatment is coming up. She's not bleeding. We thought she's dying, but she didn't. So what would you do differently if this patient was, say, 80 years old or 90 years old, but well and active and fine? What would you have done differently, Harriet? Because you were heavily involved with the case.
Yeah, so you could give more intensive.
Yeah. Yeah. So you treat the bleed more aggressively. You give FIBA. You give what? FIBA is a PCC, and you give Novo 7. Yeah. And you start steroid, cyclophosphamide, very small doses. I said 50, 60. I think still is a part of the treatment with prednisolone. And you send this patient transfer to London or Edinburgh or whatever. So Pallavi joined in, just make it interesting. The lupus screen was falsely positive because they didn't do the 2-stage test. They didn't add on more phospholipid to see the correction, and that's why they said it's a positive lupus, which I'm going to investigate because they should never have reported this as positive. Unless the patient has got a lupus inhibitor as well as the factor 8 inhibitor, extremely unlikely. I did a search, I think there are 2-3 patients in the world has both inhibitors, delayed acting and immediate acting. So that was the Pallavi, the bleeding. She came in with PB bleeding and the bladder bleed. Didn't correct. And see, she had a prolongation of the APTR started in March, but she presented that time here. And that was she had a diagnosis of the CLL stage A under Dr. Zugulu, I think for last 5-6 years, not been treated. And she was 91, came in with postmenopausal bleeding and advanced dementia. These people, just remember, always very elderly, lives in a nursing home, other comorbidities, very elderly people. So these are the studies talking about, I got a couple of slides from Dunhart from the past. You must have seen probably some of these. So as I said, you think of it, very important, diagnose it, and you don't wait to get your inhibitor study. If a patient is bleeding and you got 50-50 not correcting, isolated, prolonged APTT, just treat the patient and you treat the bleed, and then you think about treating the inhibitor. You can wait a few days. There's no urgency, but treat the bleeding is so important. And Harriet, we mentioned about this patient typically presents to A&E, rheumatology, care of the elderly, obstetrics. In your patient is obstetric patient, yeah. Quite often patient comes in. We had a case, I think, a couple of years ago. The gentleman came in to A&E, left leg swollen, 3 o'clock in the morning, and the suspected he's got DVT. His D-dimer was a bit high as well. You see, they started on low molecular weight heparin, and the next day, one of the register Ankush detected his APTT was 100, and then we immediately acted on, and we found this patient has got a massive bleeding hematoma. So muscle hematoma is one of these things. And if you expose the patient, you will see bleeding, ecchymosis everywhere. If you don't expose, you don't find it. Typically, acquired hemophilia patient bleeds not in joints, is muscle or retroperitoneal bleeding, you see.
Yeah, that's different, isn't it? So
Yeah.
with your standard hemophilia A, inherited
Yeah.
hemophilia A, Okay, joint, please.
You see toddlers, you see, and other people, they come in with plain injury or toddlers, they come in with joint bleed, typically, hot and tender joint, but typically acquired hemophilia, for some unknown reasons, they bleed soft tissues and intracranial even sometimes. You will see some cases here, so just remember these things. Yeah? So that's another case, prostate cancer, A&E, breathless and swollen cough. Initially, you always like DBT or PE. Somebody did multiple attempted use. When they come in, you see, you're just quite keen to get the breathless patient. You see, this patient had isolated prolongation of the APTT. It's always the case. It's isolated, prolonged APTT, bleeding patient coming in, just remember. That's another case, you see, Parkinson's, independent, slurred speech. So you know this from the fast. This is, I have shown another one. It is very rare. What's the incidence of the acquired hemophilia? It's about 2 to 4 per million population. So we expect to see 1 or 2 cases in Southend. So whole Chelmsford, Basildon, Southend, we probably see 2-3 cases per year. So rare, but remember these things. Yeah, this guy, you remember this one? He used to talk like this.
No.
Just remember, this one is so important. If you don't know, you don't know. Okay. There are some people not knowing, but they don't act on it. So that's quite important for us, so juniors. So typically, if you expose them, you'll find lots of bleeding and bruising in the back, on the flank, and others. So expose the patient. It's very important. And the other patient presented with cough more swollen than this one. This is not the patient. And the suspect has got proximal DBT, and they get treated with the clotting test was sent, I think, 3 o'clock in the morning, but never been checked until next day. In A&E, they gave a start dose of the dolteparin.
Even if they say it's a lupus anticoagulant, but if you see a patient like this, you know.
Yeah, that's very interesting actually.
Yeah.
You see,
Yeah.
you just, because extremely rarely, if you see the mechanism, the lupus positive patient can bleed. There are some definition about it, extremely rarely, but anybody bleeding, just ignore the lupus, it can be falsely positive. You see, this patient can have a bleeding from anywhere. So you do all this, I didn't put it on, so this acquired hemophilia is an IgG mediated antibody, autoantibodies. 30% time you will see underlying lymphoproliferative or myeloproliferative or underlying cancer or viral infection or autoimmune disease, but 70%, like others autoimmune, you don't find a cause. They can bleed from anywhere, you see. This is quite important, you see, time-dependent inhibitor. You just must remember, correcting 50-50 immediately doesn't mean anything. If you suspect an inhibitor, you always do the incubation study, 1 hour and 2 hours. It's a time-dependent antibody, so they might get immediately correction, but if you still suspect it, you ask them to incubate and do it 1 hour and 2 hours. And see typically what happened to this patient. You mixed it immediately, corrected actually, yeah? But when you incubated, was still wrong. Okay, look at the other one. Immediate, and you see as the time is going, is prolonging. So the antibody is strong, is destroying the control plasmas remaining factor VIII, and that's why the APTT is prolonged. Yeah, so just remember those, we talked about it. You have seen this when you go to London, you will have to go to the fridge with your keys and you have to open it, sign it, and give it yourself. So just see how they look like, yeah. So FIBA is activated prothrombin complex concentrate. Beriplex is inactivated PCC, so it's just activated the FIBA. And you have the Novo7. That dose, as I said, you just see like this. So bleeding patient with, anybody with bleeding, not congenital, factor 7 deficiency, get 90 microgram per kilogram, but congenital factor 7 deficiency, the dose is much smaller, it's 15 unit per kilogram body weight. Just remember that. You will be asked at some stage the doses of the bleeding patients and hemophilia patient factor 7 deficiency, which is an autosomal recessive condition.
Dr. Islam, Just
Yeah.
stop it
Oh, okay.
and then restart it. Like, stop it for 5 minutes.
Yeah, okay.
Yeah.
Yeah. There are some studies, actually I will not go in details about it. The efficacy and effectiveness of the Novo-7 and the PCC is similar actually. There has been each two studies, so it's all same. It's the matter of what you have locally and the cost effectiveness. Giving fever is about 27,000-35,000 per 24 hours. If, the Novo-7 and fever is about 12 to 15,000 pounds. Whatever you have, just give it. We have actually most of the lab they keep Novo-7 as for emergency, but if you have a patient once in a year like this, you can use it and then communicate with your tertiary to send more or transfer the patient to the facilities. Yeah, tranexamic acid you can use locally as well, so no problem with it. These are the other thing I don't think. Remember this one? Remember the financial things? Cost like this. It's quite high cost, you see. One of these patients acquired hemophilia, you sent to tertiary hospital. They stay in median hospital stay, I think, quite long, isn't it? 4 weeks usually they stay. They need lots of physiotherapy, lots of other things, social care, etc. Because they are from the nursing home. So these are the things a bit dangerous, but you have to be careful when you do these things. Mobilization, cannula, venipunctures. You have to examine and re-examine daily to assess the bleeding. It's so important. You remember this guy? Yeah, he's still there, active. So lots of people, you see, the biomedical scientists, nurse specialists, doctors, everybody, surgeons, all works together and get the patient to a place of safety. You can deal with it, deal with bleeding. Locally. Rarely you involve the surgeon if there is a bleeding causing obstruction, etc. But it's quite dangerous. That requires a lots of communication and collaboration. So you need all this, as we talked about it, yeah. And this is the place where you send the patient from our place usually.
How did it become virgin?
Eh?
How did it become virgin?
Did you see? This is Tower Bridge. This is a virgin bringing a hemophilia patient to
I
London.
thought it was London Air Ambulance.
No, the Royal London is provided by Virgin. He pays £70,000. So you bring it to A&E in here actually, Resus. Okay.
Question for Solomon and Paddy.
Yeah.
So Dr. Islam said the other common scenario apart from elderly, you see it in postpartum patients, postpartum women.
Yeah.
So in the UK, how would you treat them differently? Now you have facilities for all these things, fever, you've got Novo-7, you've got that's diuretics now, everything. How would you treat them differently? Would you treat them differently? Say you had all of these things. I think younger patients, you tend to use Novo-7 over fever because fever is partly Novo-7 is recombinant.
Yeah. So like the young patient you see, so what Pallavi is saying that you're comfortable giving them Novo-7, which is a recombinant product, and PCC comes from the multiple donor plasma, you see. So there is still a theoretical risk of plasma component and all the disease associated with. So we tend to just still use Novo-7 for young people. Yeah. Extremely rarely you can see with post-pregnancy, like other autoimmune disease like TTP, etc. So it can happen rarely. I haven't seen a young patient in my life. I've seen now probably 15 acquired hemophilia. All of them were elderly patients. Yeah. So you.
They know the triggers. I mean, I used to do a lot of this testing when I was in the lab.
Yeah.
9 years ago, when it was sort of just coming through, and what have we got? And they were mostly elderly. I wasn't aware of postpartum ones, but do they know the triggers of why they're requiring the inhibitors?
No, because as I said, it's about 30% cases you will know an underlying lymphoma, myeloproliferative or cancer, for example. We had a case with urological cancer, another one is prostate cancer, as you see, another one was myeloma. But in 70% time, you really do not know, it's idiopathic, unknown.
Maybe they're going down the line of the swine flu what was treated.
It's unusual. These usually see elderly people you see, and I don't know, usually the residential home. And all the hemophilia, acquired hemophilia we got when we were trainees, they're from Essex actually.
I know.
They were all for some reason, Basildon, Southend and Chelmsford. Yeah. But you expect to see Southend, you expect to see one at least a year.
The postpartum patient we saw is an extensive bruising on her arms by holding the baby while she was breastfeeding.
Right.
Expect
That was her
epilepsy. Yeah.
And
presentation.
how old was she?
She 30s.
Yeah,
Yeah.
sometimes you'd wonder whether you've missed 1 milligrams or something,
Yeah.
mild 1 milligrams, wouldn't you?
Yeah. So these are the patients you see when their factor is normal and they're staying in the hospital for long, you put them into thromboprophylaxis. While they come in with severe bleeding, or once their factor is normal and the bleeding is stopped, then you put them because they receive lots of PCC or NOVO7, quite prothrombotic, so you consider them thromboprophylaxis and daily examination. The clotting factors, the biochemical parameters, platelets, and examine the patient daily is so important as well.
And also you tend to avoid using tranexamic acid and one of these white acid agents concurrent. Once you start more fever or something, stop the tranexamic acid.
Yeah, yeah. You can still put the local on the tracheostomy tube and others, local compression with the gauze, but systemic fibrinolytic is relatively contraindicated. And this lady also had urological bleeding, so bladder, so you tend not to give her. She had something compression on the ureter as well, and the perinephric, so she was not on it. Okay, questions?
We should
No.
have had
Do you think
pictures
the
of
CLL was related
Connie.
Huh?
Remember Connie? Constance something.
Oh, yeah.
We were sending one of the patients.
Yeah, okay.
And pictures every week to Royland.
Pallavi, you can help yourself, have some food.
Do you think the CLL was related to the autism?
It's very unlikely. The number of the CLL, I have not seen anybody CLL associated acquired hemophilia. It's possible in theory and in lymphoproliferative disorder, but we do see at least 5-6 CLL patients. I've never seen any acquired hemophilia associated with it. It's probably unrelated. Autoimmune disease like autoimmune hemolytic anemia and the ITP is common in CLL, but I don't know whether there is any association with CLL. Probably can do a bit of search and see whether how many patients in the world had CLL as well as acquired hemophilia. Probably few. There will be always 2-3 cases. You see, it's so prevalent, isn't it?
Do you do the Bethesda now with the Royal London? It's not done at all at Southend?
No, Batista, I think when Kevin Oakley was here, he was able to do it in Southend, old lab, but not anymore.
Not
Yeah,
anymore.
yeah, yeah,
No.
yeah.
I think even in Royal London, it's only 1 or 2 people who can do
Yeah,
it.
it was here, isn't it?
Yeah.
It's
When we
just
had a
few of
patient
us.
recently, we sent the samples on Saturday morning, but it wasn't done until Monday. We just treated on clinical grounds. She had extensive bruising, undetectable factor
And this is
VIII.
what you've got to consider though, isn't it? Is the with your testing, what's available with you, what you've got now, is completely different now to how you treat the patient in that meantime.
So for me, have you come across?
Factor VIII, and
Yeah.
it wasn't correcting the factor VIII.
Have you come across any patient in Nigeria with this condition, acquired hemophilia, or never been thought of? Not really. There are patients, you see, but doing the testing and the perspective and clinical suspicion is not there, you see. I'm sure there. Because when I was a trainee in Bangladesh, they said PE and DVT, it never happens in Bangladesh. But now, everybody in the hospital and the fracture, they have a PE because they know how to test it.
Yeah.
Happens in Bangladesh. She's living in East London. It should happen that way.
Absolutely, absolutely, because they didn't suspect, you see. What typically